welcome to this meeting of the Healthcare Reform Study Group for Commonwealth North. My name is Juanetta Ayers. I'm the Executive Director for Commonwealth North. It looks like people might be a little slow in joining this morning. We've still had quite a bit of snowfall here in Anchorage, and I know other people are dealing with weather around the state, so we'll go ahead and get started in the interest of everyone's time and schedule this morning. Kathy, is that you? Kathy Giesel, is that you online with us?
This is Kathy Sullivan.
Oh, okay. All right. Thank you. All right. So I'm going to go ahead and get us started. Our speaker today is Heather Carpenter, who is the Health Policy Analyst with the Alaska Department of Health and Social Services. And here comes Ralph. And Heather was instrumental in, I believe, 2015 and 2016 when Senate Bill 74 was developed and adopted. And so we've invited Heather to revisit SB 74 and update us on what has progressed, the status of any of those items that are in the bill, and maybe what hasn't progressed as quickly as anticipated, and any other reflections on the process and what may be happening moving forward. So welcome, Heather, and I'll go ahead and spotlight you, and I know you have some slides to share as well.
Great, thank you. Okay, let me get my screen shared. Let's see. Okay, can you guys see that okay?
Yes.
Perfect. I just made some slides to help guide my conversation, and feel free, stop me, interject, ask questions, because otherwise this could be really, really boring if not. So again, my name is Heather Carpenter. I am currently the Healthcare Policy Advisor to Commissioner Crum, so at Health and Social Services, but in 2015 and 16, I was the legislative staff member that carried Senate Bill 74 for Senator Pete Kelly at the time. And it was a blast, and I learned a lot. And if I knew then what I know now, may have made some different decisions as well. So just kind of taking some time to look at where we at 5 years later. And this slide is actually from our annual Medicaid reform report that we put out on November 15th each year. And this just gives a great overview of cost savings related to Senate Bill 74, some other items that are ongoing, and general cost containment initiatives. One thing that I've learned is Medicaid reform is ongoing. It's never just one and done. So that's why you see some things here that are related to Senate Bill 74 and other initiatives that the department has taken on. Some that I just want to highlight. I won't go into a ton of detail, but in this middle section, there's items about pharmacy, and we have an amazing Medicaid pharmacy team that is really aggressive with rebates and trying to just manage the preferred drug list. We made some changes since I've been at the department that allowed managing that pharmacy drug list a lot easier. And I just can't say enough good things about the people I work with that make those items work. So I won't, spend a ton of time on this, but you can see the money is pretty substantial when you're looking at all of the efforts that the department is doing. This is another great chart. I brought lots of charts for you because I figured the visuals would be helpful. So this is from what we call our MESA report. It's the Medicaid enrollment and spending in Alaska that we have one of our economists do from Evergreen Economics. And if you look, this shows over the years how much has been spent on state funds, federal funds, and what that means with enrollment and recipients. Something to note is enrollment has obviously continued to go up, and you see a bump in the years when Medicaid expansion happened. Recipients is lower because not everybody who enrolls uses services. But the big thing is, if you look at these, blue bars, the state funds have stayed pretty flat or reduced, which is a really big deal, even though our federal funds have increased and we are serving more individuals than Medicaid. So this is another chart about spending that just shows, the trajectory the department was on before they started in earnest bending the cost curve. And that first long-term forecast in 2006, where the department was going, and then the results that have happened from ongoing Medicaid reform and spending constraints. So it's really moving in the right direction. Yes, it's still going up overall, but we have lowered that cost curve. And feel free if if I'm not seeing something in the chat box, just speak up, because it's hard to track that while I'm talking as well.
Heather, I'll just, I think it'll probably be better for you just to go ahead and walk through your slides.
Okay.
And we'll do Q&A at the end. And we'll, because we've got a manageable size group, we'll go ahead and ask people to ask their questions live at that time.
Okay, perfect. So this chart is one of the biggest cost savings from Senate Bill 74 and efforts, which is tribal reclaiming. You may have heard about those efforts, but what happens with tribal reclaiming is, you're probably aware that if an Alaska Native who is a Medicaid beneficiary and receives their care in a tribal facility, the state gets 100% FMAP. But sometimes, the tribal facilities don't have all the services, so somebody can't be served there because of specialty care, or they might need, for instance, a residential psychiatric treatment facility. So what happened in 2016, thanks to the efforts of the administration at the time, the federal government came out with what they call a show letter, a state health official, where they gave guidance on how states could basically reclaim people who have to leave the tribal system, but it's super manual. There's a lot of effort involved. It requires care coordination agreements, a sharing of records, and a referral. But despite this requiring, just extensive manual efforts to prove those records, the state has saved a total of $305 million. And that is a really, really big deal over the years. This last year, you see the total savings was less than the previous year. The simple reason for that is with the pandemic, there's been less travel, and travel is the biggest thing we usually reclaim. So I have a few slides on the 1115 waiver. Mainly because I just want to brag on our behavioral health team. But the 1115 waiver is just a huge game changer and is probably the biggest, shift that came out of Senate Bill 74. So it's a waiver that we apply for with the feds that asks us, hey, can we just waive the rules of how we, do things with Medicaid to be inventive, add new services, and really just try new things. 1115s are the way Medicaid programs across the country try innovative new practices. In the bill, this is one of the things, a lot of the options in the bill, the legislature at the time said, people may do this, the department may, it was very permissive. The 1115 was required of the department to apply for. So it's a 5-year waiver. They have to be cost neutral to the federal government. And a few fun facts. So in state fiscal year 21, over 16,700 clients were served. And a whole lot of claims were processed. So as part of this waiver and standing up the 1115, the state contracted with what we call an administrative services organization. And that we are contracted with Optum, and they actually support the behavioral health system. They run the claims through their claims payment process. So you can see I put on there, that we're paying, the ASO is paid $189.9 million in claims. That's not massive when you look at the whole world of Medicaid, but it is not insignificant either, and those claims should keep building. The three primary diagnoses are opioid-related disorders, reaction to stress and adjustment disorders, and alcohol-related disorders. And I put some links on here. I'm just going to show you one graph of what some of the new services look like. But in total, the 1115 waiver brought on 23 new services to the state, which is a really big deal. And so what's neat about this graph is you see that on the bottom, what's in green is grant funded. And the orange color is our normal Medicaid state plan. And then in the blue, these are new services that are in the 1115 waiver and reimbursed by Medicaid. Prior to this, services like that or other items would have had to be covered totally by general fund dollars in the green. So the 1115 has brought on new Medicaid services in a time when the state has had pretty significant mental health struggles in terms of serving individuals with mental health diagnoses and getting enough providers. So it's just been a huge game changer and exciting. And I want to point out, because I'll mention this on the next slide, you see some services that are related to the Crisis Now model, including 23-hour crisis stabilization, mobile outreach, and crisis residential. So like I was saying, this ties into crisis response services, and it's really, really exciting to see, the work the department has done and what's going to be built upon that. So 15 agencies across the state have applied for department approval to be 23-hour crisis observation providers, and 15 have received approval to do crisis residential stabilization. Our Division of Behavioral Health is incredible, and they're working with providers all the time on technical assistance, including how maybe a non-traditional provider can qualify as an 1115 provider and deliver these services. An example of that is they worked with the Anchorage Fire Department this summer to receive a variance so they could actually become an 1115 biller for their mobile crisis response. And as you've probably heard in the community and across the state, with the work that the trust and the department are doing together, the Crisis Now model is able to be stood up because we have the 1115 and those services that are that can be billed to Medicaid. So 3 of the 4 pillars of Crisis Now can actually be billed with Medicaid thanks to the waiver. And this just shows you visual can always help. This 1115 benefits the providers. It provides a much more stable funding stream. So instead of, like I was saying before, things being just grant funded and purely state general funds, we now have a shift where things are Medicaid billable, and we can have that offset with the federal FMAP. So already in a few years, you're seeing a pretty significant increase in Medicaid billings. So I'm just going to kind of give a list and walk through some of the implemented options. And when we get to Q&A, I can dive in more to some of these if you have questions about specific options. So we've seen increased telehealth, both at the Department of Health and Social Services and Commerce. The telehealth provisions, and some will remember in the bill, were specific to how the professional boards license telehealth providers. Prior to Senate Bill 74, you had to be physically located in the state of Alaska in order to provide telehealth. And we really wanted to just expand those options. So professional licensing has done a great job at standing up, that availability. And I know that's been just incredibly used during the pandemic. The department did do a round of coordinated care demonstration projects. There was 2 awarded at the time. The one that is still ongoing is Providence's patient-centered medical home model that went live in 2018. And I don't know if anybody from Prov has jumped on, but I'm happy to let them chat about it, or even if Jeannie wanted to share some information. And another project that I will say I'm really glad Jeannie's on is the super utilizer reduction efforts. And the first one is the what we call the Emergency Department Coordination Project, and that is led by ASHNA. And they're the ones who really brought that project to the legislature. And it has been amazing to connect emergency rooms throughout the state. this is actually how I first met Dr. Zink, was her coming and testifying on this project. So it's really helpful to allow an ED provider to have more information if they get, a frequent flyer who comes into the emergency department. With this system, it connects, so they are able to see if they were in another emergency department recently and discharged, what that treatment plan was, what the doctors did. They're able to flag if the person is seeking, just opioids and kind of jumping from doctor to doctor. And I think it's had a lot of great results, but again, I don't want to take too much credit or speak out of turn, so Jeannie could probably answer some questions on that one. And the department has had primary care case management options that we have continued to push forward and help. And this helps, so if we see what we call a super utilizer, we can lock them into a specific primary care provider and a specific pharmacy and behavioral health provider, and that can just really help steer people to the right services and try to keep them out of the emergency department. We have implemented a couple of state plan options that the bill allowed. The main one that you've probably heard of, if you've been tracking, is the 1915K Community First Choice. So this refinanced options that we were only getting 50% FMAP, and by moving them into this Community First Choice option, we actually receive a 56% FMAP. And these are services in our senior and disabilities community. We also have what we call now like a little C waiver, and that allows new services for people who are on the wait list for the full waiver. In the bill, it actually was a 1915I option, and the department at the time, under Director Dwayne Mays, did a ton of study and looked at how they could implement that, and they decided at the end of the day that it just put too much risk on the state. It didn't have enough controls and had to be pretty open-ended for enrollment. So instead, they went with a 1915C waiver that they could control, who was coming into the program and the spending on it. There's been a lot of efforts around fraud, waste, and abuse. The bill required an eligibility verification system that was run by a third party. And after several years, I'm really happy to say that the department finally has stood that up in our Division of Public Assistance. And that's going to be really helpful moving forward, especially as we move out of the pandemic. During the pandemic, we haven't been able to do what we call like an eligibility scrub or do eligibility determinations because of the requirements to maintain eligibility as it was at the beginning of the pandemic. So that system, the intent here is that when somebody applies for public assistance, it can kind of check everything. And check records outside of the state, see if people own property somewhere, and other items. So really just a great fraud tool to make sure people are eligible. There was a requirement for provider self-audits every 2 years, and the department has finally done their first round of that, even during a pandemic. And I will say that speaks volumes to our providers who were able to make this happen. And surprisingly, we've found about $800,000 in overpayments. And I was very pleased with that. And it's just another great tool in the toolbox for the department. We also, in the bill, allowed for EOBs. So, when you go to the doctor and you get your explanation of benefits, you're able to check and say, yep, this happened or didn't happen. And we're hoping that that's going to be a tool that we can, really train Medicaid beneficiaries to use. We did switch who is doing that. So that tool is more relatively new. And, I think the goal by the end of the year is to have about 2,500 people in the system and then just continue to grow that. Another large part of Senate Bill 74 was making the prescription drug monitoring program, or the PDMP, mandatory to check it. I won't go too much into that because that was a Department of Commerce responsibility, but I will say things move fast. So, the year after we passed this, where I think in Senate Bill 74, we required a weekly upload of information into the PDMP. By the next year, because of the opioid crisis, that was actually increased to daily. In the bill, there was a whole lot of things that were required in what we call the reform program. And you see a lot of those items are all reported out in our annual reports. And I just mentioned some of the reports that you can find here. You know, there is no lack of information. So if any of you are interested in information about Medicaid, and I can upload in the chat box our annual Medicaid reform report, which I have mentioned, so much great information. We really built that to be what we hoped legislators, you know, would have all the information they needed every year, as well as the public. I joke with my poor colleagues now. I tell them I'm sorry every year when we have to do this report because it's a whole lot of work. So I really hope you guys could take advantage of that and just receive the really good information in there. And we do post this on our website, as well as there's an annual fraud report the department does with the Department of Law that talks about, you know, what efforts have been made on fraud, waste, and abuse, payment error rates, and there's a lot of great information about the Medicaid fraud control unit that's at the Department of Law. And again, we have our Medicaid enrollment and spending report that I mentioned. And if you ever want to dive in on the projections and where we're going, that is an excellent long-term forecast to look at. Another item that was in the bill was allowing, and it made it not just permissive, but required the Department of Corrections to apply for Medicaid when somebody leaves the facility for 24 hours. And that's that trigger that allows DOC to use Medicaid expansion, apply for Medicaid for a prisoner. So that way, instead of DOC paying the entire healthcare bill, they're able to take advantage of that federal FMAP. Before that, it was really hard to get prisoners to agree to apply for Medicaid. This just gives you a graph of telehealth expansion that the department has seen during the public health emergency. You know, I don't think we'll ever go back to kind of how things were before. And I'm really excited to see, you know, state fiscal year 20 and 21, that just massive increase in telehealth. And for the department, the biggest increase that we've seen has come in the behavioral health world. Okay, the items still to be implemented. So in the bill, there was a Medicaid Assistance False Claims and Reporting Act. This was on the Department of Law to apply for. They did, you know, put the act forward to the Office of Inspector General, and I think it went forward a couple of times, and we just couldn't get approval. So, you know, I've talked with the counterparts at law, and there has been talk of them putting forward, you know, legislation to kind of make the tweaks that would be needed in order to get approval from the Office of Inspector General. There were civil penalties that were authorized that the department could take advantage of, and we just haven't been able to get, you know, the regulations developed yet because we were focused on the provider self-audits and other things. But that would be, you know, a next step for the department to put forward. Additionally, we can do more rounds of coordinated care demonstration projects. When we put this bill forward, you know, the intent was to have them be yearly. Like I said, if I knew now what I knew then, or yeah, you know what I'm trying to say. It is a lot of work to put out the rounds of coordinated care demonstration projects, including, you know, just the efforts that it requires of the staff, you know, getting the RFPs, the actuarial analysis. So there's only been one round. I think, you know, we're trying to figure out how we can do another round of that. Additionally, we are at the part with the Providence project that we have to have a third-party actuarial analysis to tell us, you know, hey, is this worked? Is it not worked? And give the recommendations per the bill if that should be, you know, made permanent or not. There is an option for a 1945 health home. We put this in the bill really at the request of the Alaska Primary Care Association. And I think you'll see the department move forward with this soon. This is also a recommendation in our current report from PCG about, you know, options that we should continue to pursue. There was a timing with this, you know, we can put in the option whenever. And when we do this, we get to kind of pick which 8 quarters we receive a 90% FMAP for. Some of the innovative service models and payments that were in there that haven't been implemented yet, but have been, looked at are premium payments for centers of excellence, penalties for hospital-acquired infections, and then bundled payments. And the only piece of the 1115 that hasn't been implemented yet is what we call the Imd Exclusion. And that would allow us to just waive the requirement that the federal government has that if you have 16 beds or more at an inpatient behavioral health facility, you're considered an institute of mental disease, and you can't bill Medicaid for that adult population. So the federal government does allow you to apply and have that waived, so you can then bill Medicaid for that adult population in those facilities that are over 16 beds. So that is my last slide, and I'm happy I can stop the screen share if you want, or leave it up and just answer questions.
I'll go ahead and stop that, and we will take questions and answers now. Ralph Townsend is one of our steering committee members and co-chairs, and he's with us this morning. I'm going to call on him to get us started. For everyone else, I do see a couple of questions in chat. I'm happy to read those on your behalf, or if you'd like to ask those questions live, we'll do the raise your hand. Either turn on your camera and raise your hand, or you can use the reaction button and raise your hand, and I'll watch for those in chat. That'll move you to the top of the queue. And so we'll take it from there. So let me again turn to Ralph.
Well, thanks very much, Heather. This was a great overview of what's been going on in SB 74, and I think again, I think you've got a lot of people in the audience who know the importance of SB 74 for moving ahead. Let me ask, just you gave some data at the top of the presentation about savings, and obviously the single largest item was the shift in tribal match, the 50 million or so there. Do you have a rough split of how much of the savings to the state was through shifting costs to the federal government versus what was saved for the state? Do you have an overall number for that?
Not off the top of my head. I would say a lot of this, there are some of the bigger initiatives are definitely those refinancing initiatives that, shift more money to the federal government. We actually have one of the lower FMAPs compared, to other states, but it's really hard to get your FMAP changed because, it's how the feds determine those costs. But the efforts, the 1115 was refinancing and really taking those things off of just pure general fund, making the Medicaid billable, and the same thing with the state plan options that I mentioned in the senior and disability services world.
A big focus of the initiative was in this area of new ways of incentivizing care, obviously. And as you mentioned, that turns out to be perhaps the hardest bit of the effort, particularly the issue of bundle payments and quality incentives, which are obviously on the national initiative. And then I believe that originally was supposed to be 2 coordinated care projects, and one of those projects did not get started or was terminated early. I guess it's a 2-part question. What was the other coordinated care project, and why didn't it get off the ground? And then the bigger question of how does the state, it seems to me the state still has an issue of catching up with what's going on nationally in terms of things like bundled care, quality incentives, and so forth. So that whole general area of changing the way we do business outside of behavioral health. I think we need to give some credit for the 1115 waiver and obviously behavioral health is non-trivial here, but in the traditional area as opposed to the behavioral health area.
Great questions. So yes, Alaska is like the only or one of only 2 states that are still purely fee for service. So that means, you go to the doctor and your bill charges you for everything. It's not a bundled, it's not what we call value-based care. So we're making efforts to move in that direction. The state, our Office of Rate Review, has worked closely with our hospital partners over the last year on how to implement what we call DRGs, or diagnosed related groups, and that will, be for our non-tribal, non-critical access hospitals to, kind of follow along with what Medicare has done for those kind of payments. And I believe, anticipated go live date is July with that, and that's been a long slog and good work of our folks, our contractors, ASHA and their contractors, to move forward on what that'll look like. So I'm excited for that option. You are right that when, the Walker administration put out the RFPs and was awarding the proposals for the coordinated care demonstration projects, there were two that were, had the intent to award. The Providence was the first one, the patient-centered medical home that I said, and the other one was United Healthcare for a managed care pilot in the Anchorage Bowl area. Our administration inherited that project when we came in, and there was a ton of effort that was put in, a lot of good work by both the department and United. But there were just some unknowns that made that project kind of uncertain for this administration. And part of that was just the drop in oil, prices, and what the state revenue looked like. We were nervous about moving forward. There were some unknowns with how it would work with the tribal population that we just weren't totally comfortable with, because the tribal health population could kind of jump in and out every month, and we just didn't have enough comfort with that at the beginning of the administration to move forward. We just felt like there was more to kind of work on. We're hopeful to get back to some pilot projects, like that or something else, but at the time, which was 2019, we just didn't feel like we could move forward.
Great. All right, we have a question from Elizabeth Ripley. Elizabeth, go ahead.
Good morning. Good to see you, Heather, and thank you for this recap. But I can't believe so much time has passed since we were all working on that. And just, kudos for all of your personal work and the work in the legislature but then the follow-up by the department, because it was a massive bill and with a very heavy lift. So I just want to really thank you for your leadership. You mentioned at the beginning, and you gave one example of the coordinated care demonstration projects, of things that now that you might have approached differently, besides how challenging it is to issue an RFP and really have all those ducks in a row and manage a project like that. Can you give it other examples of things that you wish we would have thought about differently?
And this is, I think how many, the coordinated care demonstration projects, of me saying like, yeah, we could do this yearly, no problem. That's the biggest one where I'm like, that's really not feasible for, I think, the department or the providers. The other one is, this was a massive bill, and I kind of think about this both ways. Like, on one hand, I'm so glad we put all of the options on the bill when we did, because it's just really hard to get legislation like this through the legislature. So then we have those menu options when we're ready to launch them. On the other hand, it's overwhelming to have the same group of people, because it's the same small group of people who are implementing all of these things. And I think that workload, the recognition, now that I'm on the other side, it's just so hard when you're doing the day-to-day work that has to be done at the departments, let alone then, adding all of these new initiatives into the pipeline, making sure they're done right. So I think just that understanding that it's really hard to do everything all at once. And if you want them to have really high quality outcomes, it's just going to take time to get all of those efforts through.
Would you have prioritized? Because I think that, I've heard some people describe it as we threw a lot of spaghetti at the wall, hoping something would stick. Because we were trying to allow for all these possibilities, some of which there were actual initiatives happening, right? And so that didn't materialize. So would you have, and how can we better prioritize essentially what's more appropriate for Alaska in this regard to both, we were trying to extend coverage and coverage that was more upstream to prevent downstream huge costs and utilization, right? I'm kind of big picture.
Yeah.
But so what would you have prioritized differently?
Well, and I think, you raise a good point. And I think as a result of us throwing the spaghetti at the wall is the department was forced to prioritize, what was going to be the biggest bang for the buck and what was going to see the most innovation and change at the time. So of course they were aggressive on the tribal reclaiming because you really needed those general fund savings. When I say that is manual, tedious work, oh my gosh, like it's by hand spreadsheet, tedious work that we're still trying to get the feds to kind of help us to make it easier. The 1115, I can't say enough good things about it. I mean, and Elizabeth, that the behavioral health, that was probably the top priority in terms of really big system changes. But I think because of throwing everything, kind of at the wall, it feels like we've lost some momentum on making changes, the value-based payment changes, because we kind of had all of these options, and I almost wish we could have narrowed them down to kind of force the department and the providers to come together and say, okay, we're going to make this work. We didn't want to limit our options, but I think it's been easy to then shift and focus on kind of some of the other initiatives, and we haven't made as much progress as I think the legislature, the department, the stakeholders that were key to the bill on really making those value-based payment strategy changes. And it's hard because it needs to go, I mean, it's not just Medicaid, this payment reform, for how do we change and make things to paying for value. You also can't look at it as only the Medicaid world, or you just miss so much. It's not even Medicaid in the grand scheme. It's not even the biggest general fund dollar for healthcare. That would be state employees, so and retirees and stuff.
Okay. All right. We have a couple of questions in chat, Heather. This one from Kathy Giesel. And Kathy, if you want to ask it live, go ahead and turn your camera on. Otherwise, I'll read it for you. Here she comes.
Sure. Good morning, Heather. It's so nice to see you. And you're the perfect person to be presenting on this. And I appreciate your knowledge. You kind of answered my question, and that is, what else can we do? It does sound like there's a lot more that you're working on implementing now that will make that big difference in this budget item. So if there's anything else you would add, I mean, something else that you identify that the legislature could do to reduce costs further. Thanks, Heather.
Yeah, and so good to see you. So I think, I read your question in the chat, you're so right. What else can we do around, fraud and continued efforts to reduce costs? So one thing that the department is going to have to do as we're coming out of the public health emergency, that's more awareness, but that, we don't need legislative permission to do this, but we need everybody's help to make sure that, Medicaid beneficiaries are aware, is that we're going to have to start doing eligibility redeterminations. Like I said, it's been about 2 years by the time, if the public health emergency is not further extended, that the department's been able to touch eligibility and kind of do that review. While it's been occurring, the only time we could unenroll somebody is if they moved out of state or were deceased. So that's going to be pretty painstaking work, as those determinations come back up. But really a shift for beneficiaries to make sure they are providing all of their documentation, responding to the Division of Public Assistance. Now, this should not be a scary thing, because if we don't do it, then it puts the state in a really rough spot. We get audit findings, it's just good practice, but we don't want people who, are our most vulnerable to lose their healthcare coverage either, who would normally be eligible. So that's kind of the biggest thing coming up in terms of, really good practices that the department's going to implement. The other thing, is just, we've had a great model, like I said, of working with ASHA on, trying to move forward with the DRGs, but we need to expand that, I think, broader to, how are we really going to bring in something that is not fee for service and truly shift, how we're paying for care. And it just takes a lot of conversation and getting people comfortable with it. People are comfortable, I think, in practice saying, yes, let's move that direction. But, when you kind of get to that reality and what it looks like, it gets really scary. So I think it's just time. We can't keep going on this trajectory, or, healthcare costs. We're still the highest in the country, which means we're the highest in the world. So we've got to do something different.
Ralph, do you have another question?
Yeah, actually, it was a follow-up on that DRG question, Heather. Sort of a three-part question. The big question is the shift to DRG a key to moving ahead in a lot of other areas? I guess the second question is, will this allow us to make clearer comparisons to other states, for example, for what we're spending? And third, DRG compensation is already in place for Medicare, and I think is widely used, the equivalent is used in insurance. Why is it such a shock to providers to shift to DRGs for Medicaid? And then I guess the last piece is not including the non-critical access and the tribal entities. That's going to be a very large part it's a large part of the coverage for Medicaid. How much of a challenge is that going to be in terms of making the next steps beyond DRGs? So that whole broad question of what's the role of DRGs? How do they fit in? What do they let us do? What don't they let us do?
Well, I think DRGs are kind of the first step. So it's a way that people were, understand and familiar with, could kind of get their arms wrapped around, like, what does this look like? And even that has taken a year plus of, we have 2 contractors working on it, focused groups meeting all the time to say, okay, what do we do? What does this look like? And you're looking at, you're trying to find the right grouper to make sure it works for Alaska. That, you're looking at, okay, are people going to lose money? Are they going to stay the same? What's the coverage going to be? So it's it's a really good practice to see what is it really going to take to do this, on a broader level. And I will say the hospitals are, I'm going to say far more sophisticated, but they just have more resources to kind of come along with the department to have those painstaking conversations because, they have large billers, they're used to doing this. Our mom and pop senior and disability services providers who might be running a small assisted living home or, a small PCA operation aren't going to have that same bandwidth to dive into some of these conversations. So, it's how do we kind of shift the whole system? And we're probably going to have to continue it with our larger providers first, who are just more stable and can have those conversations. Now, you do bring up some points that show where it's really difficult to make changes in Medicaid. And part of that is how some groups are treated because of the role they play with the federal government. So tribal health is amazing. It's an amazing, amazing resource that the state of Alaska has. But we have to interact with tribal health in a different way. We have to do tribal consultation on changes because of their, role with the federal government. They don't have to follow some of the same rules that other providers have to follow. And it's not, good, bad, and different. It's just how the system works because of how tribal health is. At the same time, it benefits the state to work with our tribal health partners because, like I said earlier, when a tribal beneficiary is receiving care in the tribal system, it's 100% FMAP. And as you know, we rely on our tribal partners out in rural Alaska because they're the only ones who are there. So in some places they're serving our veterans, and Senator Sullivan, I know, has worked really closely on making sure that could happen. So they're amazing partners, but we have to go kind of walk side by side with them and the different rules that the feds have with how, Alaska Natives and American Indians can be treated. Critical access hospitals, have a different way they're reimbursed. And so when we're looking at how a big thing can be applied, you don't always want to apply it to critical access hospitals because we could lose our infrastructure and our safety net there. And we have a lot of those, critical access hospitals across the state. So again, that leads to the challenge of when we are talking about a big change, or, if the state says, hey, the legislature or the administration says, let's do a rate reduction on hospitals, but we're only going to have it apply to the big hospitals. Well, that ends up being about 6. And so then we're hitting the same hospitals over and over again. And that's a lot of burden on them. So it's definitely a careful thing we have to walk out when we're looking at these changes, because, we don't want to just say, okay, big hospitals, you can take this hit over and over again, because they can't. And then they have to make the decisions, what services do we need to reduce? And, there's changes that can be made, but again, it requires, all of us. So I hope that answered or helped a little bit.
That was very helpful. Let me ask, one of the points you made was that the state spending has been flat. I see projections that have been used, for example, by the Joint Working Task Force that kind of project that. I'm a little surprised by the flat projections, given the aging of the population and that Medicaid is the largest provider as the provider of last resort, I think is the right way to put it, for nursing home care. Is that a hidden challenge for us looking ahead? Well, not so hidden challenge, I think. The aging is pretty clear. And is that going to put an upward pressure on Medicaid costs that people aren't really considering at this point?
I think it's something we have to be aware of, because yes, that aging population is a concern. A couple of things we've done in the state. There have been new providers that have come in the state. Maple Springs is one to provide, assisted living and nursing home level of care. But we don't have, enough beds in the state to care for everybody. However, the state has been intentional about really pursuing our waivers. So what that means is we have pretty extensive home and community-based service waivers, and there's some very intelligent people who are on this call that could probably be more eloquent than I am about them. But the state was intentional. We didn't want people just in institutions. We wanted them to be able to age at home and to get their care in their home community. So the state built up our waiver system, which is less expensive than institutions. And, I don't know if you've ever seen, and I almost put it in here, but Senior Disability Services has a great graph that shows the different costs at different service levels for individuals. And of course, institutions are the most expensive. So if we can keep people at home and, have more providers that are doing PCA care, adult daycare, et cetera, that will help, reduce that burden of the aging population. But we, some challenges I think are providers of SDS will tell you is we don't have enough care coordinators. So there's a bottleneck, especially because there's a requirement for what we call conflict-free care coordination. So you cannot get your care coordination services from the same agency that you're actually getting your, PCA or other care from. So yes, you're right. We have to figure out what are we going to do with our aging population. I think a different challenge that the department is looking at that we're really passionate about, that we've been talking about with providers, is complex patient care. We have some individuals who, are just falling through the cracks that we can do better on. And these are complex patients, whether they're youth that experience a developmental disability as well as behavioral health challenges. And we just don't have great facilities to serve them in Alaska. So as a result, we're having to send them out of state, which means they're not close to family. Family might get to visit them once a quarter instead of much more frequently. They're not around, their cultural norms, and it's, we can do better. So that also gets difficult when we have individuals who are aging and who age out of, being complex youth and then are complex adults. So, the state of Alaska doesn't have what we call an intermediate care facility that can serve this population in an institution-like setting. And I use the word institution, I should probably say facility, because, we don't want just institutions. Like I said, the state was very intentional about moving away from institutions and wanted community-based care. But as a result, we don't have some, specialized facilities that can serve those vulnerable adults and children who, have, like I said, complex medical, complex behavioral health needs. That makes it difficult to discharge patients from the hospital. We talk to providers like ANMC who might have, somebody who has a trach, and it's really difficult to discharge them because the assisted living homes aren't ready to serve them. So I think that's where we really need to go to not only allow people to be served in the state, but, kind of reduce that cost of sending them out of state.
Okay. All right. Thanks. Thanks, Ralph. Thanks, Heather. We have some other questions in chat, Heather. Sandra Heffern's online with us. I don't know, Sandra, if you want to ask this live, you can turn on your camera if you do. But basically, the question references the demonstration projects referenced in the Medicaid report and describing the patient-centered medical home model. Do you have any information regarding outcomes and whether or not the model is going to be expanded in other locations?
I don't have the info with me today, and I don't think anybody from Providence is on. What we did say in the annual report, and I'm going to attach this year's annual report because the one you posted was actually from a previous year. So it hasn't been posted yet because we're just trying to make it ADA accessible for the website. So I'll find that in just a second. So we did do a year extension of that project, which we mentioned in this year's annual report. So we can, go live, or we can look at the outcomes and, contract with an actuarial to do that analysis. So it's outside of the department. One thing that we are looking at is, the suitability of operating it under a 1915B waiver, which is a 2-year time-limited program for the option of introducing federal funding and establishing a model of care replicable by other willing and able primary care providers. I'm reading from the report, very smart people who wrote that part. So Sandra, I think we're, at that point of really doing the due analysis to see, does this make sense to expand? And that was the whole point of how the coordinated care demonstration projects were built into into the bill to make sure not only are we, asking the providers, what are the things you want to do that can be innovative, but how is the department doing the analysis to make sure that we can move forward?
Okay, great. We also have a question from Greg Smith. And just for everybody, yes, we will be posting the recording from the session. And when Heather shares her slide deck with me, I'll post that as well, along with any of the links that have been referenced. And he's asking about your thoughts about the all claims payer database.
So, the department worked and supported the legislation that was put forward by the governor on the all payer claims database. We see that as a really important shift to make sure we're looking at things beyond just Medicaid. We know Medicaid is just one piece of the puzzle, and we are, very happily working with Division of Insurance and DOA on the efforts around an all payer claims database. We know it's complicated for some to understand, but I think the benefits are very, very real to move forward in that direction.
Sure. All right. Yeah, we do have a comment from Dave Musgrave as well about some of the acronyms, and I'm right there with you, Dave. It's a new nomenclature for me, so I'm a little bit lost and have to either look up or think of some of these, but I see some thumbs up from other folks as well. So
I'm sorry, I try to remember to not give too many acronyms, and then I still fall into it.
Well, it's a very dense topic, and acronyms I think help move it along in some respects for those of you that are well aware of these. So we understand, and I see the links that you've provided. Elizabeth said Ripley is asking, have we changed our reimbursement services in the LTSS continuum to include higher reimbursement for higher acuity requiring higher staff competency?
So what Elizabeth is talking about there is the long-term services and supports. So those are the services that we're looking at in our senior and disability services world, home and community-based services. Elizabeth, I'm gonna check with SDS on that. I know it's something we've talked about, and we've done like a one-off to try to, encourage when we're trying to place a complex patient that, has a high acuity, can we do, a special high acuity rate? But I don't think it's across the board, but I think that's the things that the commissioner is looking at right now when we're talking about those complex patients. They're like just heavy on his heart right now. Like, how do we do the right thing? How do we make sure we, have the right staff? We're paying people to encourage them to be providers of those individuals who need, have high acuity needs.
And did you have a
Yeah,
follow-up?
because what happens is, all those services take the lowest acuity person they can possibly take. And there's no incentive to provide memory care for folks with Alzheimer's and related disorders. And so, and then there's no incentive for even increasing the competency of the staff who care for those individuals.
We are gonna, and you'll see it come out hopefully this month. We're putting out 2 RFIs, so requests for information from the department on providing care for these complex patients, and really asking like, what is the rate you're going to need? We want to grow those providers in the state. We know memory care is a big thing, and that RFI, one's going to be for adults, one's going to be for youth. When we're open to whatever that could look like, and really asking like, okay, if the state has some capital dollars to invest, do we have a provider who would be ready to provide the care? The other thing I just want to brag on, if you all did not know, the 4th floor of the Anchorage Pioneer Home is nearing its completion of the renovations, which includes opening that 9-bed memory care unit. And that's a really big deal that Pioneer Homes has seen a need, and they're moving in that direction. And I think, our current director of the Pioneer Homes is wonderful. Our deputy commissioner who's over them was the last director of Pioneer Homes, and we're really looking at how can we utilize that asset that we have as well to make sure we're filling this need.
Great. All right. Thanks, Elizabeth. Thanks, Heather. I'm going to make another call for anybody who wants to ask questions live. Just turn on your camera, or any additional questions in chat. In the meantime, I'm going to ask one question that's probably a real 101 question, Heather, but with the success of the 1115 waiver, how do you normalize what's contained in the waiver so that you're no longer operating under the waiver? Is that contained in the waiver process? I've just been involved in federal processes in the past where they'll call something, the Innovation Act, but then they hammer you with requirements that don't allow you to be very innovative. So I'm just wondering, how do you normalize what's contained in the waiver?
Yeah, and what you mentioned is, that's kind of the trick of Medicaid, right? We have so many requirements. It's, one thing I just want to say, and then I'll shift to your question. Like when people are like, well, just cut Medicaid, it's super easy, cut optional services. Well, we now have the Affordable Care Act. There are virtually no optional services left. Like it's just, kind of the reality that we have to operate under those federal rules, and it's really difficult, to change things. So there is that. With the waiver, the 1115 waiver, we will actually apply, it's a 5-year kind of look at a time, and we will apply for another 5 years. And there are states that operate under that 1115, kind of where you're waiving those rules for different rules, for just years and years and years. So that's what the department will do to make sure those services stay intact, and as long as we're proving things out and staying cost neutral, we get to stay in that world with the federal government, which is just so beneficial to have these lower level services. So we're, filling that continuum of care with lower level services where individuals can get into care and hopefully stop people from needing the highest level of care at API or other inpatient services.
Okay. All right. Jeannie Monk, I saw you turn on your camera. Did you want to ask a question?
No, I'm sorry. I didn't have a question. I just accidentally turned on my camera.
Okay. I understand. All right. Well, go ahead, Heather.
I was just going to say, Jeannie, I'm glad you're here. And, if anything you want to chime in about the ED project, that was you all. You were, just wonderful partners in that. I can't take credit. I just get to talk about things, but I work with wonderful people.
Thanks, Heather. No, I don't really have much to add except that it has been, it's now been in place long enough that having the information and communication is part of the standard of care. The big change is getting Alaska Psychiatric Institute as part of the system. And so that's been a huge improvement in sharing of information.
Great. All right. Well, I'm going to turn back to Ralph Townsend for any closing remarks or questions.
Well, it's sort of an overall question, Heather. The focus of the SB 74 waivers are largely on reducing inappropriate care, moving people to lower acuity, less intensive facilities for the appropriate care, and of course, shifting expenses to the federal government. As we know in Alaska, the elephant in the room is that our reimbursement rates for Medicaid are roughly twice the national average. Our Medicare rate is 125% of the national average, and our commercial rates are, again, without an APCD, it's a little hard to know exactly, but the ballpark estimate is 2 to 3 times the national average as a minimum. So how are we going to deal with the elephant in the room that simply the compensation rates in Alaska are very substantially above the rest of the country?
That is a really hard question. And I think is going to require all of us working together because, while the rates are higher than our counterparts in the lower 48, to provide services up here right now is expensive. So I think too, if you ask, if you were to go and ask the providers, like those small providers I told you in senior and disability services, they'll tell you they haven't seen a cost of living increase in 6 years or more. And part of that is, the department just couldn't do that with the, low prices of oil and just the situation we've been in for years. So I think something like that would really require a lot of outside expertise to come alongside with our Office of Rate Review, with our providers to look at what is everybody, what are the rates? Because rate setting is its own expertise, it's its own animal, and it's different. So not all rates are set by the Office of Rate Review. Our hospital rates are, our federally qualified health centers are, like there's different ones, but then we have rates that are outside of that too. So I don't have a good answer to that, except for I know it's going to require a whole lot of expertise to come alongside of us and help us. And it's probably a direction we need to look at. But when you're also looking at those rates, what is that going to mean for the commercial market? Because we know if we do something in Medicaid, that could just be shifted to, the commercial market. So we just have to be intentional about that too, that we're not making a big change to rates that is just going to grow the state budget for my friend Emily Ritchie, who's overseeing, the Alaska Care Health Program. So I think it's really being intentional about how these are all interconnected when you're the providers on the other end too. So I know that's probably not a great answer.
Well, no. I mean, we all know it's difficult. In fact, I guess I'd, following up on Monetta's comment about perhaps something of a closing comment, I just really want to thank you very much for coming in. SB 74 was an enormously complicated piece of legislation, and providing an overview, even to people who know a little bit about it, is really a hard task. And I really appreciate your coming in. And I certainly think that as Commonwealth North is trying to contribute to the discussion around what are the next steps in healthcare. I think Commonwealth North is an excellent place to get these kinds of somewhat technical discussions that, yes, we could perhaps get by the acronyms. By the way, for the group, DRGs are diagnosis-related groups, as an acronym that I threw in. But I really want to thank you, Heather, for the time and effort that you've put into presenting this, in addition to obviously the hard work that you do in making SB 74 helpful. I found this an enormously productive session, and certainly if there's, perhaps step out of line a little bit, but to say, if there are any of these particular areas like behavioral health or whatever that you or someone in the department would like to come back and talk about in more detail, I think this forum would be delighted to have the opportunity to get down into those kinds of important details. So again, thank you very much for the presentation, as well as your hard work.
Well, thank you for the time. And if you all have follow-up questions, just let me know. Happy to think about a deeper dive too. And Ralph, I'll take your question back, on those rates and kind of how we will look at things across the board. And I'll, confer with my brain trust too of Lori Winghire and Emily Ritchie and just say, hey, what are we thinking? Because like I said, we just want to make sure we're not doing things in a vacuum, but that we're really moving the whole system towards change.
Great. All right. Well, thanks indeed, Heather. Appreciate your time this morning. Just a quick commercial here at the end. We do have our 15th annual legislator meet and greet event next week, Wednesday the 8th at noon at the Denina Civic and Convention Center. And we have next week on December 9th at the same time, we'll be having Daryl Means with CMS and Center for Medicaid and Medicare Services. And so Heather, just one final thought, if you have any questions you think we should be asking Daryl, feel free to pass those along, and definitely join us if you can. And with that, wish everybody a good morning. Hope you don't have to be out on the roads here in Anchorage or elsewhere if there's bad weather. But if you do, please take care and drive safe, and hope to see you next week. Bye, everyone.